So we're going to pick up as we move more distally down the upper extremity, and we're going to come to our radius and ulna in the forearm. So let's do a little bit of palpation. Let's take a look and see if we can find the head of the radius. Where would we look for that head of the radius? Well, we should be looking up here, more proximal, up towards the elbow. And you might be able to feel it more if you are to supinate and pronate back and forth, because you should basically be feeling this head going and moving in that rotating direction as we are supinating and pronating. So you should be able to kind of feel, or at least see where that might be. You can't necessarily feel it entirely. Now, what about the styloid process? Where's that styloid process of the radius? Well, that is heading down here more distally, right at the base of the thumb, but still on that radius. So that little point that's sticking out right there by towards the thumb, I like to think of it as like it's kind of like a mini thumb as it's pointing out. That's our styloid process of the radius. And then for our dorsal tubercle. So for dorsal tubercle, we've got to go on that posterior side. So when we look at anatomical terminology, we can remember that posterior and dorsal in bipedal animals, meaning us as humans, is the same thing. So on the back of that radius, on that distal end, the little knot that kind of sticks up in the middle of the radius, and you can actually palpate that and feel that on your own. It won't move. If you're moving, you are on the carpal bones, so you've got to go a little bit higher up to not feel that movement that's happening. But that's our dorsal tubercle. Next, we've got the ulna, right? So we've got our bone of the ulna, and where do we find that olecranon? So we should be feeling right at the base of that elbow, right where we think of, like we talk about hitting our funny bone, right? The funny bone, we often think that it's humerus, right? So that's kind of why it's called the funny bone or whatnot. But actually, what it is a median nerve, the median nerve that is traveling down, or excuse me, the ulnar nerve, the ulnar nerve that is traveling down, and it actually rides very superficial to that olecranon right there. And so you will actually be able to feel it whenever you're banging on it because it's so superficial. Compared, there's not a lot of muscle that's kind of binding it in or holding it steady or protecting it. When we go for our head and our styloid process, we are going more distal down the ulna. So the head of the ulna is that distal end. And then that styloid process is, again, that part that sticks out opposite of where we saw that styloid process on the radial side. So the styloid processes kind of anchor that hand in place there. All right, so let's take a look a little bit more at our elbow joint. When we talk about what type of a joint it is, take your guess on what type of a joint it is. And it is a hinge joint, right? So it hinges, and it means that it moves in what kind of a direction? Well, with a hinge joint, you can only move in one direction or one plane of movement, and we are looking at flexion and extension. So we can hopefully see that our elbow will flex and extend. However, we don't really think of it as abducting or adducting because that would cause a lot of damage. Now, you might be asking about what about supination and pronation? That actually doesn't happen at the elbow joint itself. It actually happens at the radial ulnar joint, which is a little bit different. So the ulna is articulating. Now that this is one of the great things about our body and how things are double named to kind of go through it, right? So on our ulna, right, we have the trochlea that is now coming in contact with the trochlear, we have the trochlear notch, and then on the humerus, we have the trochlea, right? So you can see how those things are double named in that they're kind of conjoining together again. The radius is going to articulate with the capitulum or capitulum, depending on how you want to pronounce it. It can be pronounced both ways, of the humerus. So we can see that those are the two places of articulation that we have there. When we look at our ligaments of the elbow, we're going to talk about what movements do the collateral ligaments resist. Well, these are what are resisting against that abduction, adduction, or when we're appropriately calling it for the knee or for the elbow, we call it lateral and medial opening of the joint, or that varus and valgus position. Oh, that's going back to when we talked about the knee before, right? We also have the annular ligament, which just loosely holds the radius in place and allows it to rotate. So here you can see right at that head of the radius is that ulnar ligament, which is just holding the head of the radius in place so that it can still spin to create that pronation and supination. And that is where it's actually occurring instead of at the elbow joint at that radial ulnar joint held in by that annular ligament. So now varus, valgus, what was that again? So we did look at it when we were looking at our knees, right? So we had the normal position here. Here we've got varus joint position where there is stress coming in or force coming in from the medial side to the lateral side, which then opens up that lateral side for injury. Or we have the valgus joint position, in which force or stress is coming in from the lateral position or from the lateral side, and it would open up the medial side of the joint for potential injury. So valgus with an L comes from that lateral side. Well, that's the same thing as what we're talking about in our elbows. So down here in A, when you can see it, it is coming in from that force is coming from the medial side. So that would be a varus position, and it's opening up that lateral side. On B, it's coming in, that force is coming from the lateral side. So that's a valgus force, and it would be potentially opening up that medial side of the joint. So here's an example. Now, just orient yourself for a moment to look at the bones and say, okay, which bone, which extremity is this? Is it a right or is it a left? So what can we use as clues to be able to figure that out? Well, if we're assuming we're in anatomical position, which we are because we don't have crossing of the radius and the ulna, right? Our radius right here should be on our lateral side, and our ulna should be on that medial side, which means we are looking at the left arm here. So hopefully you can be able to see that. So here we've got our ulnar collateral ligament, or what we could also be calling our medial collateral ligament of the elbow. We'd have to specify it's of the elbow since we also have one of those in our knee as well. But here we've got this valgus force, so it's coming in from that lateral side, right? And it's going to potentially transmit that force across the joint and possibly be injuring right here on this ulnar collateral ligament or the medial collateral ligament of the elbow. So we can see how that might occur, in which it would then perhaps open up this area of the joint. So it opens up that medial aspect of the joint. Now, this is common in a few different sports, like tennis players and especially in pitchers in baseball. So, especially when you're looking at this guy pitching here, you can see that external rotation that's happening, and you can imagine the force that is being produced on the elbow joint as it's coming through and trying to follow through on that pitch. When that happens, that force can be so great that it acts very similarly to what we would see with that valgus force coming and impacting it. Oh, it's just coming from within instead, and we can have medial side of the joint opening. So, what happens is they often have to go in and do a surgery in order to replace it because there is tearage that is happening in that ulnar collateral ligament or that medial collateral ligament of the elbow. And what they'll actually do is come and take a small section of the palmaris longus. So, here you can see it up ahead where the webbing is. That's where the palmaris longus is now attaching into the palmar aponeurosis, and then you can follow that back to see where that palmaris longus was. And you can see the little arrow that's pointing there. So they will actually take a portion of the tendon of the palmaris longus because we actually don't have, there's about 10 to 20% of us who actually do not have a palmaris longus. Not everybody has a palmaris longus. So it's kind of crazy. So it's something that we've decided is not actually needed. We actually have a lot of other flexors so that can make up for if we do not have a palmaris longus. And so we'll take a portion of that and they will actually replace the ulnar collateral ligament with the palmaris longus. And you can see that in this final picture down here where they're actually using a portion of that palmaris longus tendon in order to replace. So this is Tommy John's surgery, known because of the original baseball player who had it many times. Right here is actually a picture of Jabba Chamberlain from the Detroit Tigers at the time, who actually you can see up by the number of the page that we're on. You can see where they went in to where the palmaris longus is and extracted a portion of the tendon. And they did that through these different openings halfway through the arm and then over towards the wrist. And then they grafted it in where that ulnar collateral ligament would go. So this is actually a picture of the surgery right after Jabba Chamberlain had it, and he decided to celebrate with a little whimsy, which I can always appreciate because he's known for it. As you can see, he's got made it into a smiley face. So his scar became a smiley face after they fixed the after they did the surgery, excuse me. So interestingly, they can do it once and it can actually hold decent effectiveness for a period of time. However, if the pitcher is to re-injure it again, even if they tried to use the other palmaris longus and graft it on, the chance of it being a successful surgery is so incredibly slim, so that they won't even do it anymore because the risk outweighs the benefits. And so if they tear it for a second time, essentially the pitching career is completely over, and they won't be able to do any kind of a sport like that because they can't really replace it and they can't put that much strain under it anymore. So now I mentioned that not everybody has a palmaris longus, and in fact, it's missing in about 10 to 20% of the population. And so you might be asking, like, do I have a palmaris longus? Is there a way for us to tell? And in fact, there is. If you take your thumb and your pinky finger and you oppose them, hopefully you remember what oppose means. You oppose them and slightly flex your wrist and look at the base of that wrist. What you'll see if you have a palmaris longus is this accentuated popping out of the tendon of the palmaris longus. It's the most superficial muscle that we have at that wrist level. It's the one that is in front of where a couple of larger thickenings of fascia are. So if you have it, you will actually be able to see it like you can see here in this picture. So we've opposed our thumb and our pinky. I also brought my fingers together as well, and I slightly flexed my wrist. And then I look at that base of where that wrist is. And if you can see that tendon pumping out, that will be your palmaris longus. Now, you might have one, you might have two of them, you might not have any of them. It's really interesting to be able to look and to compare and to see, because some people will have one on one side, but not on the other. So make sure that you're looking at both arms as you're proceeding forward to find out. All right, so talk about a moment of elbow dislocation and looking at our elbow dislocation. You can see it in this picture here. What bony prominence is in danger of being fractured during an elbow dislocation? So, when you're looking at this, what do you think? What bony prominence might be in danger of being fractured if there was an elbow dislocation? In fact, here's another picture of it, and it kind of shows it as we're in this anatomical position. You can see it in the x-ray. You can also see that deformity that's happening over here on the actual picture itself if you're looking at the back of that elbow. But this bony prominence is actually the coronoid process. So looking at our ulna that we have our olecranon, which is way out and dislocated, and we have that trochlear notch that's separating between the olecranon process and the coronoid process. And that coronoid process that is at risk of being fractured just because it is now in place where it should not be in place. And so it actually becomes threatened of being fractured when we are with an elbow dislocation. So that's one of our biggest things with elbow dislocations. All right, I've got a question for you guys. After 5 minutes of begging, Jack's parents agree to swing him all the way down the block. Can you imagine? Like, it's when the both parents are holding each one of the arms of the kid, and it's like then they like pull forward and the kid swings up. I'm sure you guys have all done this as when you were a kid. About halfway down the street, Jack erupts into tears holding his elbow. After a long and exhausted trip to the emergency room, Jack's diagnosis is dislocation of the radial head. So the radial head has popped out of where that ulnar ligament is. Which of the following statements would be true regarding this radial dislocation? Okay, so we're talking about which of the following statements would be considered true about a radial dislocation. A would be the likelihood of injury could have been reduced by having Jack flex his elbows to 90 degrees and contract his elbow flexors while swinging. B would be that tearing of the annular ligament is expected due to the firm attachment of the annular ligament to the radial head. Or C, passive or active pronation and supination would have been pain-free for Jack while the radial head was dislocated. So take a moment and take a guess on what you think it is. When we're looking, it is A, flexing the elbow. So you might not have realized that that would happen, but we could do a process of elimination. Let's look at C in itself and take a look at whenever we have some kind of an injury to a ligament, right? Or the head or the bone isn't in the ligament anymore, that is going to cause pain, right? Any movement that's happening. And right here, we're doing pronation and supination without the bone being in place, without that radial head being in that ulnar ligament. So it is going to disrupt it and you will experience huge pain while doing that. Then let's take a look at B. Why would B not be correct? Well, B would not be correct because we are talking about the annular ligament, which is actually loosely around the radial head to allow it to still be able to spin. We still need that rotation of the radial head inside of that annular ligament in order for us to have pronation and supination. So it's not a tight attachment that we have there. So left to our process of elimination, it would actually be, and it's true, that if you are going to swing a child, it is better for them to be flexing their elbows as they go and contracting their elbow flexors. And you're kind of swinging them instead like that, instead of straight armed out. The straight armed out is what produces that dislocation of the radial head. So here you can actually see this as an example, the picture of the kid being swung and he's so excited, arms are extended straight out. When it does that, it can literally just pop that radial head right out of that annular ligament, either a subluxation, which is that partial dislocation of it, or a full dislocation of it out of there. And it does cause an immense amount of pain. It's often called the nursemaid's injury or nursemaid's elbow, because think about like the nanny or the nursemaid that, you know, from olden days, and they would like tug the kid around, and the kid would be like having their hand out in the front as they're trying to like slow down, and the nursemaid's like, come on, and pulling on that arm, and could potential, and that's where we first saw it come to an existence as far as that dislocation. All right, so let's talk about the movement of flexion and extension at the level of the elbow. So what I want you to do is to, again, we're going to brainstorm first off the top of your head. What do you know of that flexes the wrist, or excuse me, we're on the elbow, that flexes the elbow? And then what do you know that extends the elbow? So we're going to pause here, brainstorm on your own, then look it up and add to your list, and then come back to be able to compare. All right, flexion of the elbow. We've got the brachialis, the biceps brachii, the brachioradialis, and a weaker contribution of the pronator teres. So those all contribute to flexion. So we do have a good 4 muscles that will flex. As far as extension goes, the only one you guys should have on your list would be the triceps brachii. The anconeus also does do it. It's not one that we study on our list. It's a small little tiny muscle. But you guys should know that the triceps brachii does extend that elbow. Here's a question for you. Which of the following are attached to the medial epicondyle of the humerus? Take a look at these options and give it a guess. So we were looking this up for our field guide assignment, and hopefully you guys came up with that it is the flexor carpi radialis. That is what is attaching to the medial epicondyle. And essentially, it's the flexors that are attaching to that medial epicondyle, and the extensors attach onto that lateral epicondyle of the humerus. All right, let's talk about muscles of supination and pronation. So looking at supination and pronation, take your guess first. I'll give you a hint that a lot of them have the words in it. So take a look at the words and figure out which muscles do it. There is an additional one as well. Then look it up to compare, and then come back and press play again to be able to correct your answers. Good. For supination, we've got the supinator. That should be a gimme. When more force is needed, then the biceps brachii will also kick in as far as supination goes. So just to realize that there is a difference between those, that if you need more force and you're doing something that just requires more strength behind it, besides just the supinator, the biceps brachii will kick in. As far as pronation goes, we have 2 of them. The pronator quadratus, I can't remember if that was on your guys' structure list, but it's located down at the level of the wrist. But you guys should definitely know the pronator teres. So pronator is in both of those muscle names, so we know that they pronate. And definitely you should be knowing the pronator teres. As I said, I can't remember if I put pronator quadratus on the list or not. All right, another question. Which of the following muscles attach to the carpals or metacarpals of the hand? So taking a look at these options, let's give it a guess. So whenever we're getting into the forearm itself, always look at the names of things, right? What you'll notice is that the names of things that attach to the carpals or metacarpals are going to contain the word carpi in them, right? Versus the digitorum, where is that going? Well, that's going to the digits. So in fact, we were looking at E for A and B, flexor carpi radialis and extensor carpi ulnaris. So just looking out here, we've got the superficial flexors of the forearm. So this is attaching onto the medial epicondyle. And remember, if we make that number 4 with our hand and put it on the base of the thumb on that medial epicondyle, you will see it goes pro, flex, palm flex. Pro is this yellow pronator teres. Flex is this green flexor carpi radialis, and it's coming down to the radial side to the carpal bones. Then we've got the palmaris longus. That palmaris longus goes down. It's the most superficial one we have in front of all of this fascia at the distal end, and then it actually will blend into the palmar aponeurosis, which is like our palmar fascia of our hand. And then that's that blue missile. And then the red is the flexor carpi ulnaris. And again, right, it's coming down and attaching right to the carpal bones on that ulnar side, which is why it's called that. So those are our superficial flexors of the arm. And we talked about how do you know if you've got the palmaris longus is by, and you can see how superficial that is, so that tissue isn't hiding it when we do that opposing of our finger and thumb and that slight wrist flexion. All right, now we're going to go a little bit deeper. So we've removed those superficial flexors, right? So now we're looking at underneath here, the flexor digitorum profundus that you can see, in which we are looking. Oh, let me go back one muscle here, right here. Okay, so underneath these colored muscles that you can see, the first muscle that's gray underneath these, like especially underneath where you can see the flexor carpi radialis and the palmaris longus, that is our flexor digitorum superficialis, right? So we've removed now these 4 muscles and the superficialis muscle to look at this picture right here. And what you'll see is you've got the blue muscle that's coming down and innervating all the digits. That's the flexor digitorum profundus. Profound means deep. So that's why we're seeing it so deep, and that's why it's called that. And then the red muscle, we've got the flexor pollicis longus. So remember, pollicis means thumb. So as it's coming down, it's going to come and innervate towards that thumb. And then you can actually pick it up and see the tendon more even distal to here, but it's not colored in this particular drawing. And then we talked about the pronator quadratus, which is the most deep muscle that we have, hugging the bone of the radius and the ulna. And it has more of a transverse fiber direction. So it's actually going more cross-sectionally as compared to lengthwise down the arm. So that's our pronator quadratus that we have there. All right, so now we're flipping over and we're looking at the extensor side, right? The extensor side, everything's originating from the lateral epicondyle is what we're looking at for that origination point that we have, right? We start with the brachioradialis and we can work our way through, and remember we have the longus brevis, longus indices. So, right, we're looking here. We've got the extensor carpi radialis longus, then the extensor carpi radialis brevis. Now working to the next arrow, the ADDuctor pollicis longus, then the extensor pollicis brevis, the extensor pollicis longus, and then extensor indices. And this picture shows it better than when we were looking at our pre-lab stuff or our lab activities that we were doing. And you can see it heading towards that index finger. Again, though, it actually originates way over on the ulnar side and then dives across to go to our index finger, our pointer finger. Right here, what do we have here? What's this one? Hopefully you are saying it is the extensor digitorum longus that we have. We do have an extensor digitorum brevis, but it's just located in the hand itself, and we're not studying hand muscles this term. Then what about this muscle? It's not going down to all of the digits, but it is going down to one of them, our pinky finger. So this is our extensor digiti minimi. I think of an Austin Powers like a mini-me. Remember when he uses his pinky up against his opening of his mouth? And then we've got one more muscle over on this side, which is hopefully you're getting our extensor carpi ulnaris. So those are our extensors on the superficial side that we're looking at. Now, when we remove those, we can actually get a better picture of these muscles that are underneath. So here it's showing you the anconius is right here. As I said, that's not one that we're studying. It's a very tiny little muscle that we have right here. But underneath that, we've got our supinator, which is going to help to supinate our forearm. Then we've got our ADDuctor pollicis longus. Remember, we were seeing these from that superficial point of view, but we were only seeing these sections, the most those most lateral points of it. But you can see now that number 3, abductor pollicis longus, and number 5, the extensor pollicis brevis. Then now you can see also with number 4 where it's attaching on to the ulna itself and then coming down. And this is our extensor pollicis longus. And that's what you can see coming through with that tendon. And then, as I said, coming completely from medial over to lateral, but we're pronated, so you got to keep that in mind, is our extensor indices right here and coming over and pointing, leading towards our index finger. All right. Now, I'm not going to have you do the activity in class because I think that I have to spend a lot of time trying to explain it. But I want you to imagine what I'm tasking you with is to create a schematic to help you remember the muscles responsible for flexion, extension, abduction, and adduction of the wrist. And I want you to think of it as using a transverse cross section of the arm itself. So cut out at the level of the wrist and looking at it from that point of view. And consider how the muscles of the wrist are responsible for more than one movement, right? Because a lot of them do more than one movement. So, what I usually walk through in class, and I'm going to explain to you here, is that we take this section of the hand. We're not actually looking at the hand, but you could also be looking at it from looking at it up from the arm, from the hand towards the arm as well. But we're just looking at a picture of this cross sectional of the hand. And if we were to take and cut, sever, I don't know, draw a line between the middle of the wrist, separating it from the anterior side versus the posterior side, what we'll see is that you can see there's a pretty good delineation. Here's our carpal bones that you can see with the spongy bone inside of it. Here you can see a bunch of muscle tendons inside of this carpal tunnel that we have right here. It's what we call our carpal tunnel. Then we've got a whole bunch of tendons also on this posterior side, on the exterior side are where all of the extensors are. So when we look at this line and we cut it in half, everything that is anterior to that mythological line is going to help to flex either the wrist or the digits. And then everything that is posterior to it is going to extend the wrist and or the digits. So we're looking at flexion is towards the front, right? So it's our anterior flexion and then our posterior extension. And so anything, when we're just looking at the muscles and thinking of where these are, anything that's on that anterior side is going to end up flexing, and anything on that posterior side is going to end up extending. Now, what we can also do is separate it from right versus left, right? And take a look at right versus left. Everything, or in here, we're going to take a look at medial versus lateral, because really that's what it is. Looking at medial versus lateral. Now, everything on that lateral side is really going to help contribute at some point to abduction. Then everything on that medial side will help contribute towards ADDuction, right? So ADDuction is towards that ulnar side. We can also call it ulnar deviation if we wanted. Abduction is on that radial side, and we could also call it radial deviation of the wrist. So I like this kind of quadrant thing because now what you can say is anything in this upper left quadrant that you guys are looking at would be muscles that both flex and adduct. That's typically what we're seeing. And then everything that's in the next quadrant over on the top, both flex and ADDuct. Working our way around in the circle, everything that's in that right underneath that quadrant is going to both extend and ADDuct. And then everything in this lower left hand quadrant, our medial exterior quadrant, is going to extend an ADDuct. So I just like to look at it to help us put a frame of reference so we can start to visualize these movements just a little bit better. Now, I also just want to point out for a moment, we'll get to this as we get into injury prevention and management, but here in this carpal tunnel right here of what you can see, we've got a sheath that houses a good portion of our flexor muscles. And also what you can see right here is a little nerve, and this nerve is called the median nerve, and it's located pretty superficial as far as the front of our wrist goes. And so whenever we're like typing on computers and things like that, and our wrists are resting on something, it's often compressing that median nerve. Also, if we have injury or inflammation of any of the muscles that are located within this, it's a retinaculum, is what you're seeing. It's what it's called, but it's our carpal tunnel right there. If there's any inflammation in there, it's going to also put pressure on that median nerve. And that's what carpal tunnel syndrome is. We'll talk about that more as we get into injury and prevention next term. All right, so we're talking about the wrist. What flexes the wrist? So when we're looking at it, try to visualize, right? And think about what is it that is on that anterior side, either medial or lateral or in the middle, to be able to aid with flexion of the wrist. Well, one thing I'm hoping that is coming to your mind right away is the flexor carpi ulnaris and the flexor carpi radialis. So hopefully you're getting it has flexor in there. So it's definitely going to contribute towards flexing of the wrist because it's the carpal bones that it's being flexed. So those ones are the ones I want you to know off the top of your head. Also, having information, but you don't necessarily have to have this memorized, but being able to look it up in your field guides would be things like the Palmaris Longus, the Flexor pollicis longus, the Flexor digitorum superficialis and profundus. They do contribute more weakly because a lot of them go and flex further down the hand, like the digits or the thumb, or the palm of the hand coming up. And so they are smaller contributors, but definitely know the flexor carpi ulnaris and flexor carpi radialis as our ones you should know off the top of your head. Now, taking a look at extension, following suit, what do we think would be the ones for extension? Hopefully, what you're doing is coming up with the extensor carpi ulnaris and extensor carpi radialis longus and brevis, because we do have two of those. So those are the ones I would want you to know right off the top of your head. But now taking a cue from what we have up above, some extra ones that we would need to consider is that also contribute are the extensor digitorum, the extensor pollicis longus, and the extensor digiti minimi and extensor indices. So those do all help contribute to wrist flexion, just a lot more minimal because they mostly focus on the digits themselves. All right, here's a question. This is a precursor to what we're going to look at next. So, which of the following produce a deduction of the wrist? So, here we're going to do a little testing tip as we go. Okay, so the first thing I want you to do is when you're looking at a question, this is just literally teaching you about test taking skills. Okay, the first thing I would want you to do when you read this question is to cover up the answers that are provided. Okay, so just don't even pay attention to them, cover them up. And I want you to think, just coming up with your own answer, what would you be thinking about that you might want to include in it prior to even looking at what the possibilities are, right? So I just want you to be thinking about it. Okay, ADDuction. What have we already talked about with ADDuction and what muscles ADDuct the wrist? Ooh, do I remember that? I'm not going to give you the hint yet, but then what I want you to do is uncover one answer at a time. Extensor carpi radialis longus. Treat it as a true or false question. Is this true or is this false? If I think it's true, I could put like a little check mark next to that answer. If I think it's false, I could put like a slash through it. Or if I'm not sure, maybe I put like a little dot next to it or a question mark or just leave it like, oh, I'm not exactly sure. But I'm deciding for myself, true or false, the extensor carpi radialis leads to a deduction of the wrist. Then I'm going to go to my next one. ADDuctor pollicis longus. All right, does that contribute to a deduction of the wrist? True or false? And I had put my mark next to this answer, or in my head. I realize we're on a computer when we're doing this, but in my head, I would be putting that down there, right? Then we've got the flexor carpi radialis. True or false? And I would make a note of that to myself, true or false for that. Then we've got the flexor carpi ulnaris. True or false? So just treat them each as a true or false question. All right. And our last answer is none of the above. So if I got through and I was like, nope, not that one. Nope, not that one. Nope, not that one. Nope, not that one. Then of course, none of the above would be my answer. Right. But this is just kind of teaching you this test taking strategy. So right now, I want you to go ahead and give the answer to this question. So we are looking at our flexor carpi ulnaris. So the answer was D. Hopefully you went through that because remember the ulnar side, anything that's on that medial side is what's going to cause a deduction of that wrist. All right, so taking a look, a abduction, or also known as our radial deviation. What are we looking at? The extensor carpi radialis, longus and brevis, and the flexor carpi radialis. So notice that they have radialis in that terminology. So that's why I love the forearm. As confusing as it seems, they actually give you the things in the name of the muscles themselves. So those are the ones I would expect you to know right off the top of your head. Anything that is saying radialis is towards radial deviation, which is that abduction. Now there are some extras that do it as well, the abductor pollicis longus and the extensor pollicis brevis. However, those are weaker contributors, and I would just expect you to be able to look them up on more complicated questions. All right, a deduction, ulnar deviation. Well, we already had one of them. And so, in looking at the cue from up above, it's going to contain anything that contains the word ulnaris in it. So the extensor carpi ulnaris and the flexor carpi ulnaris are both ones that contribute. So those I would expect you to know off the top of your head for a deduction of the wrist. And then there really isn't another one that does for extras. Those are just the ones for a deduction. All right, an office mate complains of difficulty while typing one morning. You perform a number of range of motion tests, with them involving the wrist and the hand. You notice that active flexion of the digits is weak, but not painful. Passive flexion and extension of the digits is not painful. In addition, resisted flexion of the digits is weak, but he does not complain of pain. So taking a look, what have we got? Work through the wording, narrow it down. Okay, so we've got active and resisted flexion of the digits is weak, but not painful. Everything else is fine, right? So that's what we're coming down to. So weak, flexion, both active and resisted. All right, here is our answers. I want you to go ahead and read through them and take your best guess on what you think it is. Good. So hopefully you got here that it is a nerve. It's a nerve. Why is it a nerve? It's a nerve because we don't have the pain associated with it also. Then it would be a muscle. But what we've noticed is that it's weak but non-painful. right? So it's just the weakness, which means it is the nerve. And the one that it is impeding are the ones that are going towards the flexors, right? Because flexing, either active or resisted flexing, is what's being affected. And so here I won't expect you to know which nerves innervate, but I will always give you the nerves that innervate it for you to be able to take a guess off of it. So you should have been able to come up with, hey, these are the muscles that contribute to that, but it's not a muscle, which means it's the nerve that actually innervates those muscles themselves. All right, taking a look at the wrist joint just really quickly. We're going to look at a few more pictures of it and look at the hand itself. So the wrist joint itself, is it a type of synovial joint? It is a condyloid joint. So our wrist is a condyloid joint. And which of the following movements allows for the greatest excursion? So what do we have? We've got flexion and extension. What can you do the most of? You definitely can do more flexion than extension, hopefully. You'll notice that. And then we also have abduction and adduction, right? But that is not as accentuated in our wrist compared to flexion and extension. So flexion and extension definitely are the most, with flexion being the most movement and extension being not quite as much. And then abduction and adduction is actually kind of difficult to do, but it does do it, right? We do have that radial deviation and ulnar deviation. But why is it that this is happening? Well, a lot of it comes down to the shape of the bones. And I'm not necessarily talking about the carpal bones themselves, but instead I'm talking about the radius and the ulna, in which we have the styloid processes. The styloid processes are making it so we can't really do that deviation to either side, or that abduction and adduction, as easily as we can do flexion and extension, right? It doesn't happen as easily as with our flexion and extension. So we don't have as much abduction and adduction compared to flexion and extension. So taking a look at our hand bones for just a minute, there are cool ways for us to be able to remember them. I'm going to try to walk you through some of them. The one that is probably the most noteworthy or known the most is an acronym that starts, it's a mnemonic that we use. Mnemonic is just looking at ways to remember things. And you're going to start medial, right? And you're going to work from proximal to distal, in a circular motion. So this was our thumb. So that's the lateral side, right? On the left side that you guys are looking at. And then we have our pinky on that other side. So starting right underneath that pinky, the order they're going to go in, the yellow is the pisiform. This is please tell little Susie Tucker to come home. So we started with the pisiform. We worked circular, going out proximal first and then coming back around on the distal side, and followed that little saying, please tell little Susie Tucker to come home. So we've got the yellow is the pisiform, the green is the triquetrum, the blue is the lunate. This orangish reddish, I'm not exactly sure, is the scaphoid, right? So that's Susie Tucker. Right underneath the thumb is the trapezium. I like to remember that trapezium is under the thumb, because there's 3 different ones that have a T that it starts with. So I like to remember it that way. The gray is the trapezoid. I like that because it's trapped in between other bones. So I try to remember it that way. And then we've got the capitate, which I don't even know what color that is. Slate blue, maybe something like that. And then pink is our hamate. And remember, we also have the hook of the hamate that you can kind of see right here. Both the hook of the hamate and the pisiform, you can actually palpate on your hand if you're underneath that fatty, the eminence that we have right there. So the pisiform, if you relax your hand and slightly flex it, you can actually wiggle that pisiform around. And then just slightly as we go more distal and it's just ever so slightly more distal and more lateral to where that pisiform is, and you press on it, it's very tender. And that is because that is the hook of the hamate and it's got a lot of muscle attachment to it. Now, this is one of the memory aids people use. I actually prefer this one. It goes by row and it goes lateral to medial. It does the proximal row first and then the distal row. And it's some lovers try positions that they can't handle. Now, I don't just like it because it talks about sex. I like it because it actually gives me a hint on one of the names of the three bones that start with a T, and that's the tri, because this tri is the triquetrum. So the scaphoid, the lunate, the triquetrum, the pisiform, right? And then we're moving to the, if you come back, so let's see, we were some lovers try positions. So that's the scaphoid. Lovers is lunate. The tri is the triquetrum. And then the pisiform is positions. And then we go back under the thumb again so that they can't handle. That is our trapezium. Then we have they, which is the trapezoid. Then the C for can't is capitate. And then handle is the H for the hamate. So that's just another way to look at the bones of the hand itself. I tend to like that one better because I like that it gives me one of those T's because I know it's the triquetrum. All right. What type of a fracture is referred to as a Colles fracture? Have you ever had a Colles fracture or heard of someone who had a Colles fracture? It is the fracture of the distal end of our radius. And it's often, I'm not going to answer that yet because it's a question. What do you think the mechanism of injury is for the Colles fracture? Well, it's often the fall on an outstretched hand. There are so many different injuries that can happen from a fall on an outstretched hand. A Colles fracture, dislocation of our shoulder, shoulder separation. We got a lot of things that can happen there, right? But that's another one. So it's the distal end. All right, so we kind of talked about the palpating, right? So you can feel that pisiform, you can feel that hook of the hamate. The scaphoid is what you can feel, that first bone underneath the thumb. That's usually what you can feel, like it's hard to get to the trapezium. I mean, you can get to the trapezium, but kind of like right at that base of that thumb, that's where you can feel that scaphoid bone. And then our metacarpals, where do we find our metacarpals? Well, that is in the palm of our hands, right? So it's actually covered all by the palm of our hands. And then the phalanges are our fingers that we can actually move and see, and they're external to that palm. So those are our phalanges, all of our digits and our fingers. If someone tells you they've broken their wrist, quote unquote, which carpal bone are they usually referring to? So if you had to take a guess, which one do you think it would be if they broke their wrist? What's the most likely one to be broken? Well, that would be the scaphoid bone. The scaphoid bone is the first one to make impact when you are extending your hand and falling on the outstretched hand. Now, why is the scaphoid bone breaking such an issue? Well, because the radial artery is located right next to it, and it actually comes in and feeds the bone itself. And if you break the scaphoid bone, there's always the potential of severing that portion of the radial artery that's coming off to feed the bone over here. And it can actually start to die, just like what we saw. Um, just like what we saw with the hip injury with Bo Jackson earlier in the term, right? If we don't have blood supply going to that bone or that portion of the bone, it can actually start to necrose. And then they would have to go in and perform surgery and try to bypass it in order to heal that area again. And again, the mechanism of injury is a fall on the extended wrist, on an outstretched hand, right? So scaphoid bone, Colles fracture, shoulder separation, all the broken, like even the sternoclavicular ligament can sometimes happen. So it just transmits that force all the way up the arm itself. So when this happens, It can be, you can see the necrosis that would start to come in from that scaphoid bone, and they would have to go in and cut things away. All right, that is what I have for you guys to finish off our last topic that we have for anatomy for this term. So, thank you for paying attention and participating in all the activities. And we'll come back and review